Well, good afternoon, and thank you for joining us today. Yesterday we learned from the state that the county will remain in the red tier, which allows some businesses to operate with restrictions, and that's good news. We appreciate the efforts of our local businesses and residents to continue practicing safe measures that allow us to remain in that tier and prevent us from falling back into harsher restrictions. We know it hasn't been easy. But as has been clear from the very beginning, and certainly from the national events this past week, coronavirus is still out there, it's still with us, and it's still spreading. So we need to continue to take safety precautions like wearing facial coverings and obviously maintaining social distancing and avoiding large gatherings. One of the reasons the county has avoided harsher restrictions is because of our aggressive testing efforts throughout the San Diego County region. Last week, we expanded testing sites and launched a program to test school personnel. And this past Sunday, we opened another testing site in Chula Vista. The site is at the South Chula Vista Library, and it's very unique because it's the first site that we've done in partnership with one of our local cities. The city of Chula Vista is providing space, personnel, and even using its own portion of the Federal CARES Act funding, which was provided through the County of San Diego, to stand up this operation. Just to give you a few statistics, last Sunday, the first day, we thought maybe we'd get 50 people to come through. We had 245. On Monday, we had 297. And then on Tuesday, yesterday, we had 319. So obviously, this has struck a good chord with the community, and there's a lot of people taking advantage of this free service. They can get the tests while staying in their car, and it's operating Sunday through Thursday from 12:30 in the afternoon until 6 p.m. on those 4 days. I want to thank Chula Vista Mayor Mary Salas and the Chula Vista City Council for their leadership during this crisis. She and many others at the City of Chula Vista recognized the need to respond to this virus that has hit South County certainly particularly hard. When we talked about all of us working together to continue this fight against this pandemic, this is what we have been asking for and hoping for, that we get good cooperation from all of the other jurisdictions, and certainly I welcome other cities to join the County of San Diego and explore ways to partner with us as well. Before we get into our updates, I want to give a plug for the county's Emergency Rental Assistance Program. This program can provide one-time rental assistance for up to $3,000 for qualified residents who have suffered economically from the pandemic and face eviction. The deadline to apply is tomorrow, so there's some urgency if you want to take advantage of this opportunity. We wanted to give this one last push for it. If you're interested, please visit www.sdhcd.org. With that, we'll move right into our updates. We're going to have Supervisor Fletcher and then Dr. Wooten with us today. There is a new health equity metric that relates to the state's blueprint for reopening, and we'll get into that as well. Supervisor Fletcher.
Thank you, Chairman Cox, and good afternoon. In San Diego County, over the last couple of weeks, we've certainly seen our case rate stay relatively flat, which has kept us at that upper edge of the red tier. We know that San Diegans are by and large doing an incredible job of adapting their daily life to follow those basic guidance and things we've seen. Of course, we want us to do more. We want to be more vigilant, and we want to shift the conversation away from each week anxiety over are we going to be in the higher purple tier to a conversation about how quickly can we lower our case count to go to the lower tier. And so it's really important that as we continue to move forward with what we're doing, that we remain very committed and very vigilant about our actions. It's also important in a time in which certainly the national conversation around COVID is so chaotic and oftentimes distracting that we not lose sight of the simple reality that this is a deadly virus, that the ability of it to spread when people lower their guard, when people don't follow the guidance is out there and is very prevalent. I was reminded today that in just 8 months of this year, COVID-19 has killed 9 times more people in the United States than the flu did for the entire year last year. Again, in just 8 months, a new virus that did not even get going robustly until the spring has killed 9 times more people than the flu did all of last year. This is not the flu, and we have to be mindful of that, and we have to recognize that even if the federal government is going to have an erratic and inconsistent message, here in San Diego County, our message is clear. The way that we open up businesses, the way we get schools going, the way we restore large sections of our life is by coming together to slow the spread. That means wearing a mask, avoiding large indoor gatherings, staying home if you're sick, and physically distancing from folks who do not live in your household. And if we do those things, then we can be a model and continue to make as much progress as possible while we await a vaccine or therapeutic treatment. In a little bit, you're going to hear from Dr. Wooten around the new health equity metrics the state of California is putting out. We're awaiting additional guidance from them, but we know and have discussed time and again that COVID has not hit every community the same. Historic inequities that are present have been exacerbated by COVID-19, and we've certainly been doing everything we can, moving testing sites, moving testing locations. Recently launched a partnership with the Mexican consulate, the Catholic Church. We're launching partnerships with cities and nonprofits for those communities that are most impacted, those communities of color, those historically underserved communities. We're doing the same with contact tracing, significant work and effort around doing it in a culturally competent way in the right language, partnering with nonprofits and trusted community representatives, and we will continue to push to do even more to tackle issues of equity, and we look forward to additional guidance from the state of California to make sure we're doing everything that we can, and we'll see what those numbers go to. And then, as Supervisor Cox mentioned, again, tomorrow is the deadline for our rental assistance program. It is a proposal that Chairman Cox and I brought forward together. We have $24 million available for residents in our county who are having difficulty paying their rent because of this pandemic, and we encourage you, please, by the end of the day tomorrow, go to coronavirus-sd.com and sign up for the rental assistance that is available. With that, let's jump into our charts for today. We'll start right here. We've had a significant, a steady increase in the number of testing we've been doing, which is good in terms of providing more insight into what's happening, and it also helps with state adjustment factors. But what you see right here is we've been able to do this without compromising our turnaround times. San Diego County Public Health Labs remain at between 1 and 2 days turnaround times for testing. Our county and Helix partnership is between 1 and 1.5 days. You see the hospitals there a little bit slower, 1.5 to 2.5. State walk-in labs continue to do very well. Federally qualified health clinics continue to do very well, and commercial labs holding steady. And so it's important that we keep an eye not only in increasing testing, but also being able to ensure the quick turnaround time. And as of right now, we're doing both. We'll go to our next chart here. Today, we're reporting a 7-day average of 9,264 tests. This is an increase that has helped bring down the average percentage of new cases that are positive to 2.9%. Total testing over 1.1 million. There you see our efforts around contact tracing and case investigation, total cases performed, and the treatment statistics on the right-hand side. For today's cases, today we're reporting a total of 354 new positive cases, over 10,000 total tests done, so a 3% percentage of positive there. And the purple line, again, you see the 14-day rolling average of percentage of positive. That's trending in a good direction, and you can see the significant uptick in testing along with the day-to-day variance. Again, 1 day's stats are not as important as the overall trends and where we're headed. As it relates to hospitalization, ICU is currently at 73. Total COVID-related hospitalization at 286, slight uptick, but generally consistent with where we were, say, 3 weeks ago. So you see that holding generally steady, up, down a little bit, and something we will continue to monitor every day. Total hospitalization, we take the COVID 286 on the bottom there. All other hospitalizations now at 4601, which is still below that 80% bed capacity trigger that we monitor as one of ours. And then final stat is our ICU capacity. Again, remarkably flat and steady right there at 66%. 73 COVID, 384 non-COVID, and this has been one of our most consistently stable metrics we've seen. That concludes my section of the report. I'll now turn it over to Dr. Wooten for her Public Health Officer's update. Thank you.
Good afternoon, everyone, and thank you, Supervisor Fletcher. As of today, there are approximately 36 million confirmed cases worldwide of COVID-19 and over 1 million deaths. Nationwide, there are over 7.5 million, which includes over 211,000 deaths. And for San Diego County, today the local case count is 49,175 cases, which is 354 more cases than yesterday. This overall total number of cases includes 813 deaths, with 7 new deaths reported since yesterday. The age range of cases is from 0 months to 102 years of age. That has not changed in the recent weeks. The percentage of age groups, 58% for the 20 to 49-year-old age group, and this also remains. Our female individuals account for 51% of the total number of cases, and males for 49%. That also has not substantially changed. And then 7%, or 3,626 of the cases have been hospitalized. Now, of the hospitalized number, 839 have been admitted to the ICU, and this number is approximately 2% of the overall number of cases and 23% of the total number of those hospitalized. The total number of cases includes 813 deaths, or 1.7% of the total number of cases. Now, next I'll review COVID-19 demographics related to hospitalized cases. And again, the demographics and the percentages have not significantly changed here either. Of the 3,626 total hospitalizations, 2,607 cases, or 73% of the total cases hospitalized, are among 50 years of age and older age group. Males represent the majority of those hospitalized at 54%. Hispanics and Latinos represent the majority of those hospitalized at 61%. The next slide speaks to further demographics related to deaths. 348, or 43% of the total number of deaths are female, 465, or 57% are male. Of the 813 deaths, 776, or 95%, have had underlying medical conditions, and the remaining 37, or 5%, did not have any underlying medical conditions. And as a reminder, again, the top 3 categories for underlying medical conditions includes hypertension, diabetes, and heart disease. Now, moving on to the next slide, focused on our triggers dashboard. And as you will see here, community outbreaks is the only metric in the 13 metrics that is abnormal, and also the total number of outbreaks is declining. So we are reporting, as of today, 15 total community outbreaks for the past 7 days, from September 30th to October 6th, which represents 74 cases. Also today, 9 new community outbreaks were reported in the following sectors, and you see them listed here. From 1 in a barbershop, 3 in businesses, 1 in a food processing facility, 1 in a grocery store, 2 in restaurants only, and 1 in a restaurant/bar. Moving on to the blueprint for a safer economy. As everyone is aware, this tier framework with metrics and thresholds for each county to open more sectors was released almost a month ago. This system is based on levels of disease transmission, from widespread, representing the purple tier, substantial, which is the red tier, moderate, which is the orange tier, and minimal, which is the yellow tier. San Diego, as a reminder, remains in substantial or red tier, or tier 2. So for the weeks ending September 20th through September 26th, San Diego County's unadjusted case rate dropped from 7.2% to 7%, and the adjusted case rate dropped from 6.7 to 6.5. The testing positivity remains to be, or continues rather, to be in the orange tier or tier 3, and has remained at 3.5% for the entire county. Now, the county cannot move into the orange tier until the case rate is below 3.9 cases per 100,000 population for 2 consecutive weeks. That would require the region to report an average of 133 or fewer cases each day, which to date has not been achieved. The county, or rather the California Department of Public Health, will assess counties on a weekly basis, and the next report is scheduled for next Tuesday, October 13th. Now, the California Department of Public Health now has 3 metrics. If you go to the next slide. So we've provided results for number 1 and number 2. Now there is a 3rd metric that is focusing on health equity. It is important to note that this metric will be utilized to assess advancing to a less restrictive tier. It will not, however, be used to move us to a more restrictive tier. So that is the good news there. The health equity metric highlights areas of concern in communities that require additional support and resources to ensure that the test positivity rate for these communities is not sufficiently higher than a county's overall test positivity rate. So for us to defeat COVID-19 and fully reopen our economy safely, we need to ensure that all communities and our essential workforce have access to testing, to treatment, and protections in place to help them be successful. Now, the health equity, people might ask the question, what is health equity? And this is the definition that is used across the nation. Health equity is achieved when everyone has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. And we like to refer to those circumstances as social determinants of health, which is what health equity is based on. The county's Live Well San Diego vision, specifically for the thriving component, is based upon the foundation of health equity, which again is addressing the social determinants of health, which determines the health of a community. Keep in mind that it takes years, if not decades or generations, in some cases, to change some of the social determinants of health or community conditions. The new health equity metric incentivizes counties to decrease infections across every neighborhood, and the counties with the lowest or low disparities move quicker through the tiered system, and counties with large disparities move slower through the tiered system. The health equity metric is based on the Healthy Places Index, or HPI, where each community area receives an HPI score. HPI is a tool that looks at 6 healthy community conditions or health disparity areas that influence health and predicts life expectancy in a community. And these areas include economics, education, transportation, social factors, neighborhood or environmental factors, as well as housing conditions. And based on the HPI, a region is categorized into 4 groups. And the highest to the lowest quartile are the healthiest to the least healthiest communities. The testing positivity percentage is calculated for areas scored as the lowest healthy communities. The health equity testing positivity percentage will place counties in one of the lower tiers. But this metric will not move counties to a more restrictive tier. So for example, San Diego is in the red tier. This metric will not move us to the purple tier, but it will assist us in moving to the orange or yellow tier. At this point, with our overall case rates and the actual testing positivity for our lowest tier it will be difficult at this point in time, and as you see here on this slide, it will be difficult to move to the orange tier. We are currently 6.2%. To move to the orange tier, we have to be less than 5.2% for the lowest quartiles or the least healthiest communities. So that will be the focus. Today, we will get a template for a plan that must be submitted to the state on next Thursday, and the state is also developing a playbook, which will be released next Monday. So we will take the guidance and make sure that we include all of the activities that are currently being conducted to address health equity in general. So the immediate strategies to decrease the testing positivity score for the lowest healthy communities include, the first thing is outreach and education. And we have a great network through Live Well San Diego to educate the community. The second is focused on testing, then contact tracing, and then isolation and quarantine support. There are other strategies that will be included in the playbook, and we will include those in our plan once the documentation to develop our plan is received. The county has done a great job in these areas to date, but we can always do better. And in working with our community partners, we will strive to do just that. The county will be required, as I stated, to submit a plan of action next week to provide what strategies are being implemented, and the playbook will be sent to us in just at the beginning of next week. So for more information about the blueprint for a safer economy, we encourage you to visit covid19.ca.gov. Now, in closing, we can only succeed and open up more sectors with your help. Please continue to work on these simple prevention strategies by washing your hands and promoting sanitation best practices, staying 6 feet, at least 6 feet from others, wearing a facial covering, and avoiding crowds and staying home if you are sick. By using these strategies, we can decrease the testing positivity rate and the case rate to progress to a lower, less restrictive tier. If we lower the testing positivity rate and case rate, more sectors can open, and this is the goal for what we are all doing, so that we can increase openings for our various sectors. But again, we have to do it in accordance with the guidance that we have received and following the metrics that we are following from the state. So now please welcome back to the podium Supervisor Greg Cox. Thank you.
Thank you, Dr. Wooten. Before we get into the questions, I just wanted to clarify one point that I made in my comments. The South Chula Vista Library is actually located at 389 Orange Avenue in Chula Vista. I think I misstated the hours of operation. It's actually from 12:30 to 8 p.m. Sunday through Thursday. So Sunday, Monday, Tuesday, Wednesday, Thursday, it will be open from 12:30 to 8 p.m. With that, we'll go to the first question.
Priya Schroeder, NBC 7.
Hi there, Dr. Wooten. You just spoke about some of the strategies that you guys are going to do to try to get our equity score a little bit better. But how would you explain the disparity that we have so far with our equity score being at 6.2% and the overall county score being at 3.5?
Okay, Dr. Wooten.
Thank you for that question. We know that all communities are not equal across any given jurisdiction. And for those communities that have greater resources based on social determinants of health, those are the areas that we are not focusing on. We are focusing on those areas where communities have decreased resources. So this is not a new concept. It really is focusing on social determinants of health. Social determinants of health are the factors related to education, the environment, transportation, economy, that help to, that contribute to the health of individuals. So we will be looking at what we can do. As I stated, these are some of the social determinants of health are things that take years, decades, and even generations to change. But we will provide the resources that we can provide, and provide the resources where we have influence, and do that to help decrease that score. The things that I mentioned, testing, making sure that people that are positive are isolated, or if they've been exposed or quarantined, as well as the contact tracing, how fast we can get to individuals to remove them from the general population if they are determined to be have exposure to a positive case. Those are things that we have been doing and we will continue to do in collaboration with our community partners. There are other things, though, that we can and will do, focusing on the homeless population. You are aware of what our actions are there. Providing child care for individuals, as well as transportation and physical access and mobility. We have focused on data. If you go to our website, that's another strategy to inform the community. Communication is a big strategy, as well as focusing on language access and cultural competency, translating our materials into over 8 different languages, and we do that for all of our health officers' orders as well as other important documents. And then the community engagement with our stakeholders, our various sectors. We have over 20 sectors that have been created out of the 4 primary sectors for Live Well San Diego. So we've done a lot, but we will be looking at what other areas we can improve in once we get the playbook from the state. Thank you.
Okay, we'll move on to the next question.
Sasha Fu, KUSI.
I'm picking up on Priya's question and Dr. Wooten, your comment that you've done a lot, especially in the testing area. That's been pretty impressive. But what area do you think could see much more improvement at this time? There are some structural barriers to, for instance, people who want to isolate when they're in households where that is very, very difficult. What are some of the other areas where you think the county can make greater strides?
Okay, Dr. Wooten.
So I have some comments, and then Supervisor Fletcher will also have comments. I think other areas for improvement have begun by creating partnerships with organizations in the community that are that have a primary focus, whether it is on the Latinx or African Americans, refugees, or immigrants, as well as the Asian Pacific Islanders, and also utilizing our promotors to go out and reach those individuals that we have not been able to reach because people might be afraid of government or making the connection or talking to us. So those are areas that we certainly can improve in. Supervisor Fletcher.
We've taken a number of actions and steps from the beginning of this process. Obviously, initially, it was moving significant testing into communities that were more impacted. We did that by setting up testing. On the contact tracing part, we've done considerable work and effort bringing in contact tracers with trusted partners, working with nonprofits in the communities, our Promotora program. Obviously, our public health motel rooms are a huge asset for folks who are lower income, that they don't have to make a choice between potentially exposing people in their household, especially if it's a multi-generational household or a household with a higher number of people. They have a safe place that they can go. The efforts our board recently took around income assistance. for some individuals who might not be eligible for the other things that are there. Again, we don't want someone to make a choice between I have to go to work in order to provide for my family, or I choose to have to follow the public health guidance to quarantine or to isolate. Now we have the ability to provide that. Certainly the rental assistance program, the Wi-Fi program is designed to help families who don't have access to that. And so time and again, we've stepped up to try and look at every opportunity we can to support every community out there, particularly those hardest hit and most impacted. But undoubtedly, there's more that we can do. And so even though we've done all of those things and we'll continue to do those, we will always search out more opportunities to try and address the equity issues and try and help those communities who are most impacted.
Can I have a follow-up question?
Okay.
Hello?
Yep.
Yeah, despite all those very, laudable proactive measures, there's still this fairly large disparity between the overall county rate and the rate in the most disadvantaged communities. So is it even realistic to think that we can narrow this disparity and become much more equitable in terms of our health outcomes?
Well, COVID didn't.
Even realistic?
COVID-19 didn't create the inequities in our society. They've been created over generations of time. It has certainly exacerbated them and it has highlighted them. And so what we're fighting against is generations of folks not having access to health care. What we're fighting against is an environment that was created pre-COVID where a lot of communities in San Diego don't trust government agencies and government entities. And so I think it is certainly possible that we can make it better. I don't think it's possible that we can just wipe away hundreds of years of challenges that have been created, but we have to get in there and fight for every single community, and we have to get in there and fight to make sure we're doing everything we possibly can to try and make it better. A lot of these communities that are more impacted obviously are people of color, they're lower income, they're also service workers that are expected to go to work, and they're expected to figure out how to help their kids Zoom learn, and they're expected how to navigate through it all in an environment where they may not have traditional access to health care, relationships with the doctor or health system. And so we're going to continue to fight to do every possible thing we can do and continue to challenge ourselves internally every day to say, what else could we do? What more could we do? How could we do what we're doing better in an effort to try and mitigate it and limit the damage? I don't think we can just magically erase all the problems that we face in our society, but we can fight every single day to do the very best possible.
Thank you.
Okay, next question.
Anthony Pura, 10 News.
Yes, hello. I think you mentioned some of it there, Supervisor Fletcher, but can we just clarify just which disenfranchised communities we're really focusing on to bring up our health equity score, and can these be broken down geographically?
Okay, I believe both Dr. Wooten and Supervisor Fletcher are going to respond.
Yes, we get a report from the state. The state develops the results for the lowest quartile, and we get that information. And the information is shared with us what those communities are. So as we get that information, we will begin to work with community partners and look at, number one, testing. And do an overlay of that. Do we have adequate test sites in those various locations? What are the community partners, who are the community partners that we're working with in those locations? So we will be looking at all of those factors and many more as we begin to develop our report to be submitted next Thursday.
I would just add to that, the state has the new criteria for the health equity metric, which is based on census tracts and incomes and a variety of factors. To date, a lot of our efforts have been around cases and where we've seen the higher prevalence and higher percentage of cases. In many instances, those align, and so we will certainly continue our efforts in those. But there could be areas where we need to reassess and reprioritize and rethink what we're doing. And so I think, throughout the entirety of COVID, we've daily said every day you have to learn something new and you have to be willing to shift and adapt. With the new state health equity metrics, we'll certainly be willing to do that and see if there's areas we can improve or adjust what we're doing.
Now, how
Okay, we'll go to the next question.
Mary Plummer, iNewsSource.
Hi there. Thanks for taking the question. As you all mentioned, the official count of deaths in San Diego County is now over 800. When you step back and look at the full loss the pandemic has caused in the region, what's your assessment of the accuracy of that number? Do you feel the county has done a good job capturing all COVID deaths or likely COVID deaths?
Okay, I'm going to let Dr. Wooten and perhaps Dr. McDonald respond to that question.
Sure. I think I'll just first comment by saying that over 800 San Diegans we know have died in conjunction with this pandemic, and our hearts and thoughts go out to each one of those individuals. Those cases are counted in a specific way. We have positive PCR tests for each one of those cases, and we know that the illness that they had was directly related to illness that's associated with COVID. So we're confident that those cases are indeed counted correctly. It is possible that there are other deaths that have occurred in San Diego that are not being counted in our system. There may be individuals who were not tested, individuals that perhaps are not county residents who died in San Diego, who are maybe in the overall numbers of individuals who died in San Diego, but not in the numbers that we report, because we only report on county residents. I would say that my estimation would be that there were probably another 10% more individuals who died in San Diego who are not residents who died of COVID. But we think that we have been able to pick up most of those cases. In fact, I'd say that we're doing better over time now that testing is much more available. I think it may be that there were some deaths that occurred early on during the pandemic, say in March and April, that may have been attributed or may have been due to COVID, but not attributed to COVID. But I think that that is not really a problem going forward.
Okay, we'll go to the next question.
Our final caller is Paul Sisson, San Diego Union Tribune.
Hi, thanks for taking my call. I'm interested in this health equity score, of course. It feels to me like county ought to know a little bit about this already, just from its contact tracing process, where you're interviewing everybody who is testing positive and then interviewing their close contacts. What are they telling you about what it is that's driving illness in these areas? Are you finding that most of these folks live in impacted households? Are you finding that most of these folks have service jobs? What is it that you're finding through contact tracing that could inform your approach in terms of bringing this number down?
Okay, Dr. McDonald's going to respond.
I think that's a very insightful question, Paul. I do think that that there is a disproportionate impact on essential workers. Essential workers tend to be lower income than some of the non-essential workers in the county. I can say that those may be individuals who might rely on public transportation more often. They are living in parts of the county that are more densely populated, the number of individuals who live in the household. They might be individuals who are binational, going back and forth to Mexico frequently for economic reasons, to buy things that are less expensive, to access health care that's less expensive. So we are seeing those types of stories being told to us in our contact tracing in terms of what is contributing to each potential set of exposures. But what we do when we're interviewing individuals is try to figure out if there are other individuals at risk that can be assisted in some way by the resources that have been discussed earlier today, whether it means removing somebody from a crowded household and putting them into a hotel room, making sure that they have income support if that's what they qualify for, hooking them up to people who can do that type of evaluation, setting them up, linking them to health care that they might not have needed heretofore. And so those processes really have been worked on in the county for really over a decade, really a long period of time, and we are applying them in this specific instance. And we're trying to do it in conjunction with those contact tracing and case investigation events. And we are finding that many of these individuals do, in fact, qualify for a lot of things that they didn't know that they qualified for. And that has been an interesting aspect, actually, of the case investigation process, is making sure that each of the people who are involved in those investigations knows how to do an effective handoff to other people within the county or to non-governmental organizations to get these individuals the help that they need.
Right. I mean, it seems to me that, you know, in covering this, that you guys have really tried to go in with a scalpel and try to figure out, or a microscope, whatever metaphor you want to use, and try to just identify these folks who need a little additional help and help them. Why do you think that hasn't quite borne fruit yet? Is it just that it takes more months than have yet been spent, and we're going to see the results of this work in another month's time? What's the lag here?
Well, I think it's a great question. I think actually Supervisor Fletcher made a good comment about this. Decades of inequity and mistrust and imbalance in resources can't be fixed immediately. Even though you can be very well-intentioned, and certainly with one person in front of you, you can try to connect them to the resources that they need. But when you look at a bigger picture, it's hard to solve that quickly. Doesn't mean that we aren't working at it one step at a time, but it is hard to sort of flip a switch and make it suddenly better, because for many people things just don't suddenly get better like that. It takes a lot of time, effort, and connecting with resources.
Thank you.
So, Paul, I was just going to additionally add, testing is very important here. Now, as this new health equity metric has been developed, our score has been lower, it's been higher, and right now it's at 6.2%. Previously, at one point in time, it was 8%, and then at another time, it was below 6. But again, it's really predicated on making sure that all of the tests are submitted and sent up to the state. And as you know, we've had an adjudication process with the state, making sure that they capture all of the tests that are performed in San Diego County. So that's a part of the process. But as Dr. McDonald stated, a lot of these things we have been doing. And as I stated in my opening comments, these are social determinants of health, and these factors set people up to have greater exposure to COVID-19. So what we're trying to do is to look at those things that we have influence on, and the isolation and quarantine, conducting the contact tracing of cases, and for that, a lion's share, most of the contacts are household members of the primary cases. So, and in certain parts of the county, there's the high density, multi-generational family members living in the same household. As Dr. McDonald stated, people getting to their jobs, utilizing transportation. So all of these factors, these social determinants of health, set people up for a greater exposure to COVID-19. So we are trying to look at all of those various factors and address the needs of the individual cases and those individuals that come in contact with them. Thank you.
Thank you.
We're moving now into the texted questions, and the first one has to do with applying the state metrics to smaller populations, and Dr. Wooten's going to respond.
This question is from Cliff Albert with Kogo Radio. Yeah. Some parents last week said that while the Sweetwater Union High School District zip code has a higher case rate, applying metrics to smaller populations delineated by zip codes is not fair and establishes physically impossible criteria that cannot be achieved. They say the district may not exit Tier 1 even for the 2021-22 school year. Is it unfair?
So first, I need to make some clarification. San Diego is not in Tier 1. And secondly, we do not develop the tier metrics by school districts. So we make decisions based on the overall case rates for the county of San Diego. The only variation where you drill down this new health equity metric, where we look at the lowest tier, which has the highest or the least healthiest communities, that's the only variation, but we do not calculate case rates or either actually testing positivity for the school districts.
All right, and this next question is from Misha DeBono with Fox 5. Can we expect stricter mask requirements based on the governor's tweet over the weekend about lowering mask only in between bites while dining? And is there any added health benefit for doing so?
So I can tell you that our current health officer's order is more restrictive than the state order in terms of the fact that when people are sitting at the table, we require that they wear the mask, the facial covering, except when they are eating. We are not, however, recommending that people put their mask on, take the mask down with bites, because then that way you are touching the mask a lot. So we have to marry kind of, and I don't mean any disrespect here, but we just have to marry what's practical with the associated risk. So that's what we've done here in San Diego.
Okay, and this question is from Anthony Pura with 10 News, I believe. If you have time, never mind. We've seen large crowds take the streets with the Padres in the playoffs. Friday night's win led to some large crowds downtown. Have there been any cases or outbreaks associated to last week's celebrations? And should it be a concern, as most of these crowds appear to take place outdoors in the streets?
Well, number one, while we recommend that activities take place outdoors, that does not remove a risk for contracting COVID-19, number one. Number two, it's a bit early to determine if a particular event that occurred on Friday night has resulted in any COVID-19 cases. Usually you see cases from 5 to 7 days after an event if there was an exposure at that event. So it's a bit early to tell if there are any cases, and certainly any outbreaks, because that's even more down the road.
Thank you.
This next question is dealing with how COVID spreads, and Dr. McDonald is going to respond to that question.
This question is from Daniel Wheaton from the Union Tribune. An article in the Atlantic last week discussed another means of measuring how often SARS-CoV spreads, the variable known as K, and it's a measure of how much a virus is dispersed. The way I'm understanding it is that K can be a means of showing how often super spreading events can occur. Based on the county's contact tracing efforts, is the region seeing outbreaks in which one person infects a large number of people, or is the number of people infected in an outbreak closer to the 3-person threshold?
Yeah, thanks for that question. I actually read that article in the Atlantic also, and there's two concepts, one of which we talk a lot about here, which is called R0, which is the average number of individuals that are expected to be infected when one person got the disease and they're exposing other people. And we've talked a lot about how that number needs to be below 1 in order to keep the outbreak under control. This concept of K has to do with the spread in a population by clusters. The idea that maybe 80% of infections are just due to maybe 20% of the people, that a small number of people are spreading a lot compared to maybe a lot of people just spreading only a few times. The analogy I would use is if there's 10 people in a room and one guy's got $1 million in his pocket and the other 9 have nothing, you can say, everybody's got, on average, $100,000 in their pocket. But actually, one guy's got $1 million and everybody else has nothing. So you want to find that guy that's got the $1 million is what this concept is all about. And have we found individuals who appear to be spreading a lot? We haven't found a specific individual in San Diego, but we certainly have found by history specific events in which it looks like perhaps one infectious person exposed a group of individuals. An example I might use is if, say, 24 individuals who haven't seen each other for a while go to a restaurant together, spend a couple hours eating and drinking, and then maybe go to one person's house afterwards and then spend another couple hours together. That 4-hour period in which these 20 or so individuals spend time together, result in a number of infections, you can say that is a clustering type event. And that actual example I use is a specific event that's actually happened in San Diego. And there have been other events that are similar to that. We could look at the cases that occurred at San Diego State University, for example. That was a very large increase in cases over a very short period of time. And it is likely that one or more clustering type events occurred in that student population, probably related to social gatherings at apartment buildings and other places off campus that then led to this large number of cases. So to answer the question, yes, we see clusters occurring in San Diego, which is why it's very important that individuals do what the public health officer orders say, which is to socially distance, not have gatherings, to not have house parties. And if you are keeping the clusters that you're involved in down to a minimum, the chance of you being in one of those super spreading events is going to be greatly reduced.
Thank you, Dr. McDonald.
This next question deals with the trigger on hospitalization rates, and Rob Sills, the director of our Medical Operations Center, is going to respond.
The question is from Taryn Mento with KPBS News. Yesterday and Monday, the trigger on hospitalization rates was reached, but I see it is now back down to an acceptable number. Number one, what explains that up and down? Number two, how concerned are you about the rate of hospitalization? And number three, is the county still talking with the state to consider this and other metrics when adjusting the case rate?
All right. Karen, yes, the hospitalization rate for the confirmed COVID patients, the trigger is we look at the 3 days and compare it to the previous 3 days and look to see if there's a 10% increase. And that is something we're concerned with. That's why we have it there as a trigger, and we keep our eyes on it. And when we see fluctuations that go beyond that 10%, reach out to our hospital partners and do further conversations and dig down to see what that is. But it seems to be in the normal variation of our day-to-day hospitals operations, no real concern. And I think for number three, yes, we are still in conversations with the state regarding that as a trigger and how that relates. So thank you.
Thank you.
This next question deals with coronavirus survival rates, and Dr. Wooten will respond.
COVID survival rates are, this question is from Mike McKinnon with KUSI News. COVID survival rates are over 99% for people under 69 years old, but we haven't progressed through Newsom's reopening stages. With false positives, it is mathematically impossible to advance to the least restrictive tier. Do you think Newsom's guidelines are too restrictive?
You know, everybody talks about utilizing the hospitalization rates as factors to determining whether we close or open. But remember, hospitalization is further downstream. That's why the focus is upstream on testing positivity and case rates. Now, hospitalizations are very important, and as Rob Sales just stated, we monitor that very closely. We have continue to send information to the state or bring it up in meetings on how we can use hospitalizations as a positive factor to gain points, if you will, in some of the metrics. Again, these are discussions and questions that we bring up through various avenues on a periodic basis. But I think the metrics that we are using are the appropriate metrics, and we follow a host of other metrics focused on surveillance, focused on hospitalization, and focused on public health response, because there are a myriad of different factors that contribute to our response. But the key focus is on case rates and testing positivity. Dr. McDonald.
Sure, and I just wanted to quickly add that this concept that false positives makes something mathematically impossible for us to do something needs to be addressed. You know, the metrics that we talk about here and present here are on confirmed cases per 100,000, not tests per 100,000, it's confirmed cases. And when we get a test result reported to us, we actually do an investigation. And we can determine that some of those are indeed false positives, and those are not counted as confirmed cases, and we do not report on those. So I think it's important to know that this idea that false positives are a significant problem, particularly at this time, just isn't true. What's causing us to be where we are is actual transmission of the disease in the community. That's what the issue is. In fact, there is probably transmission in the disease that's not being detected because we need to do more testing, we need to do more identification, and there is such a thing as false negatives, which is an important concept also. So I think, again, there may be a time when the rates are much lower than they are now, that we may need to look at precisely how many tests are being given and look at whether the small number of false positives are contributing to any degree to what we are doing with non-pharmacologic interventions, but that is not an issue now and really should not be a concern.
Well, that completes our calls for today. We want to thank you for your participation, and just a very quick reminder that we're going to be returning next Wednesday at 2:30 p.m. for our next briefing. And between now and then, we certainly hope everyone stays safe in San Diego, and go Padres. Thank you.